Anesthesia is, at heart, the controlled calming of the brain. In this film, we'll meet the drugs that do it, the sedatives, and learn not just how each one works, but how the body clears it, and when you'd reach for one rather than another. Let's start with the brake that all of them lean on. First, a word that gets used loosely, sedation. It isn't one fixed state, it's a sliding scale. Turn the dial a little and you get anxiolysis, just taking the edge off. A bit further and the patient is sleepy but rousable. Further still is deep sedation, and at the far end, full general anesthesia. The same drug can sit anywhere on this dial depending on the dose. So our real job is to land on the right point and stay there. Every thought, every movement starts with a brain cell firing. To stay calm and controlled, the brain needs a brake, and that brake is a chemical called GABA. When GABA is released, it lands on a receptor that is really a tiny gate for chloride. The gate opens, chloride flows into the cell, and the inside becomes more negative. A more negative cell is harder to fire. So GABA doesn't switch the neuron off, it just makes it harder to set off. Almost every sedative we use works by leaning on this one brake. Let's zoom right in on that gate. It's built from 5 protein pieces, 5 subunits, arranged in a ring around a central core. The usual recipe is 2 alpha, 2 beta, and 1 gamma. GABA itself binds where alpha meets beta, but there's a second separate pocket where alpha meets gamma, and that pocket is where the benzodiazepines will act. 2 different sites on the very same gate. Hold on to that because it explains a lot. The exact subunits a receptor is built from decide what it does. Gates built with alpha-1 drive sedation, the loss of memory, and the anticonvulsant effect. Alpha-2 gates relax muscle and melt anxiety. Alpha-5 gates sit in the hippocampus and shape memory. And a special group built with a delta subunit sits just outside the synapse, setting a constant background tone. Different gates, different jobs, which is why one sedative can feel quite different from another. Those gates work in 2 modes. Inside the synapse, gamma-containing gates open in quick, sharp bursts. That's phasic inhibition. Just outside, the delta gates stay gently open all the time. That's tonic inhibition, the brain's resting tone. Now, the single most tested idea in this whole topic. Benzodiazepines make the gate open more often. They raise the frequency. Barbiturates make each opening last longer. They raise the duration. Same channel, 2 different levers. Frequency for benzos, duration for barbiturates. Start with the benzodiazepines. The key to their safety is that they're modulators, not agonists. On their own, they do nothing to the gate. They only work when GABA is already there. They just make GABA's own effect a little stronger. Because they can't open the gate by themselves, there's a ceiling to how far they can push. That ceiling is why a benzodiazepine, given alone, rarely stops someone breathing, and why they're among the safest sedatives we have. 3 benzodiazepines cover most of practice, and the difference that matters is how the body clears them. Midazolam is the sprinter, fast in, short acting, but the liver turns it into an active metabolite, alpha-hydroxymidazolam, that the kidneys then remove. So in kidney failure, or after a long infusion, it piles up and sedation drags on. Lorazepam is the middle ground. The liver simply tags it with glucuronide and is done, leaving nothing active behind, which makes it dependable when the liver is sick. Diazepam is the marathoner. It's broken into desmethyldiazepam. It's self-active and very long-lived, so a single dose can linger for days. Same family, 3 very different exits. So which do you reach for? For a quick procedure, a sprint, midazolam's fast-on, fast-off suits perfectly. For status epilepticus, you want something that stays, so lorazepam, with no fading active leftover, is the classic choice. For alcohol withdrawal, a long-acting drug like diazepam gives a smooth, self-tapering ride. And a warning for intensive care, run midazolam as a continuous infusion and its active metabolite accumulates, so patients wake slowly and confused. One big reason the unit has moved away from it. There is an antidote. Flumazenil sits in that same benzo pocket and competes the drug out, waking the patient. But use it with respect. It's short-acting, shorter than the benzo it's reversing, so the patient can sink back to sleep after it wears off. That's resedation. It also lowers the seizure threshold, which is dangerous in someone who takes benzodiazepines regularly, or who has overdosed on a fit-provoking drug. So flumazenil is a careful, watched reversal, not a casual switch-off. Now propofol, the drug behind that familiar white syringe. It also works on the GABA-A gate at its own site, and its magic is timing. It goes in fast and it leaves fast. Because the body clears it very quickly, the liver and even sites beyond the liver chew through it. That high clearance means that even after a long infusion, patients wake promptly. It smooths the airway, it even settles nausea. But it drops blood pressure and it stings going in. For day-to-day anesthesia and short-term sedation, it's the workhorse. Propofol has one rare but deadly trap: propofol infusion syndrome. Push it hard and long, think more than 4 milligrams per kilo per hour for over a day, and cellular energy production can fail. The signs are a stubborn metabolic acidosis, muscle breaking down, a rising potassium, and a heart that starts to fail. The lesson is simple: cap the dose, watch for it, and if you see it, stop the propofol at once. Before propofol, induction belonged to the barbiturates, thiopentone above all. Remember the lever: barbiturates hold each gate open longer, but at high doses they do something frightening. They prise the gate open even with no GABA present at all. That removes the safety ceiling, so an overdose can shut the brain right down. They still have uses, controlling seizures and protecting a swollen brain by quietening it, but they're unforgiving. Their clearance saturates so the effect lingers, and in anyone with porphyria they're outright banned. Powerful and easy to misjudge. Etomidate is the drug you pick when the blood pressure can't take a hit, a failing heart, a patient in shock, because it puts the patient to sleep while barely touching the circulation. That stability is its gift. Its curse is the adrenal gland. Even a single dose blocks an enzyme, 11-beta-hydroxylase, and stuns the body's stress hormone factory for hours. Add some twitching on the way down and pain on injection, and you have a drug with a very specific niche: a calm induction for an unstable heart. Used knowingly. Step away from the GABA gate now, because the next two drugs work somewhere else entirely. Dexmedetomidine and clonidine switch on alpha-2 receptors in a small brainstem nucleus, the locus coeruleus, that governs arousal. Quieten it, and you get a remarkable kind of sleep. The patient drifts off, but can still be roused to cooperate. And crucially, breathing is barely touched. They also blunt pain, sparing opioids. The price is a slow heart and a lowered blood pressure. Dexmedetomidine is cleared by the liver. Clonidine doubles as a blood pressure drug. This cooperative sedation is exactly what a modern intensive care unit wants. And one more outsider: ketamine. It blocks a different receptor altogether, the NMDA receptor, producing a strange dissociative state, as if the mind is disconnected from the body. What makes it special in a crisis is what it doesn't do. It keeps the airway working, it keeps blood pressure up, and it can even open tight airways. So it shines in trauma, in asthma, and for painful procedures. It's metabolized to norketamine, which is itself active and keeps the effect going. The cost is vivid emergence streams as it wears off. Put it together at the bedside of a ventilated patient. The modern rule is less is more. Treat pain first. Much of what looks like agitation is simply pain. Then add only as much sedation as you need, aiming for a calm but rousable patient, not a coma. Lift the sedation once a day to check. And reach for benzodiazepines last, because they breed delirium. Propofol and dexmedetomidine are the everyday backbone. Light, targeted, pain-first sedation. That's the goal. That advice isn't a hunch. It's earned from trials. Men's compared dexmedetomidine with lorazepam and found more days alive and free of delirium. Sedcom put it against midazolam, just as sedated, but less delirium, at the cost of a slower heart. Midex and Prodex showed dexmedetomidine sedates as well as midazolam or propofol while getting patients off the ventilator sooner and able to communicate. And Spice 3, the big one, found that using it early didn't save more lives outright and brought more slow heartbeats. The thread, it isn't magic, but it spares the brain the delirium that benzodiazepines cause. The patient's individual characteristics matter. In elderly patients, every sedative hits harder and lingers longer, and benzodiazepines especially can increase the risk of delirium and falls, so start low. When the liver is failing, avoid drugs with long-active leftovers. A glucuronidated benzodiazepine like lorazepam is gentler. When the kidneys fail, remember midazolam's active metabolite can accumulate, so sedation drags on. And in pregnancy, benzodiazepines near delivery can leave a floppy, sleepy baby, while ketamine is often the kinder choice. Match the drug to the patient's clearance, not just the label. Before we finish, the traps worth tattooing on your memory. Benzodiazepines raise frequency, barbiturates raise duration. Flumazenil can let a patient resedate, so keep watching. A single dose of etomidate still suppresses the adrenal gland. Propofol, pushed too hard for too long, risks the infusion syndrome. Dexmedetomidine slows the heart, and midazolam's active metabolite piles up when the kidneys fail. Get those 6 right, and you've got the heart of sedation. So that's sedation. Almost every drug here leans on one brake, GABA, while our two outsiders, dexmedetomidine and ketamine, work the arousal switch and the NMDA receptor instead. What really separates them is how the body clears them. That's what tells you which to choose, when they'll linger, and when to avoid them altogether. Measure the patient, match the clearance, and keep the dial exactly where you want it. That's AnesCore.